All right, welcome to panel number 4, Supporting Wounds to Wellness, Connecting Community Resources. Here to introduce the panel is Jessica Walton. She's a MITRE colleague and a blogger on mental health issues and in the security field. Blogger on mental health issues in the security field. That's very interesting. Thank you. Please.
Hi, everyone. Jessica Walton. This is my second year participating in this symposium. Very excited to be here. So our next panel is titled Whole Health, with a focus on supporting wounds to wellness, connecting community resources. Our panelists are going to discuss how to leverage a more holistic national approach to improving mental health outcomes and wellness. So I guess I'll go around this way. Okay, so our first panelist, Nick Armstrong, is the head of Public Sector Cabana, a mental health technology company collaborating with employers, government, and the U.S. military to innovate access to mental health support. Previously, Nick was the managing director for the D'Amelio Institute for Veterans and Military Families at Syracuse University, overseeing the development of a prominent research and evaluation team. In 2019, Nick was named to the HillVets 100 list of the nation's 100 most influential veterans and community advocates. Our other panelist, Raul Andrews Jr., is the executive director of the American Psychiatric Association Foundation, an affiliate charity of the APA. Previously, he held various leadership positions with the American Association of Retired Persons, or AARP, including as vice president. In recognition of his social impact, Raul received the 2023 Star of the Bar Award for the Women's Bar Association of DC and a U.S. Presidential Lifetime Achievement Award for volunteer service. Last but not least, our facilitator, Professor Deborah Harmon-Pugh, is a retired military spouse of 27 years, the National Campaign Chair for Women Veterans Rock, and the president of the Healthy Caregiver Community Foundation. She is also the executive director of the Women Veterans Civic Leadership Institute and the Women Veterans Public Delegation on Capitol Hill. All right, take it away, Deb.
Well, thank you so much, Jessica, and good afternoon. I am very excited to welcome our guests. This is panel number 4, as was stated by our introduction. And panel number 4 is dedicating this discussion to supporting wounds to wellness. We are analyzing ways in which we can connect community resources. I'm delighted to be able to welcome you both here with us today, Mr. Andrews and Mr. Armstrong. Welcome.
Thank you.
Thank you for joining us this afternoon. I'd like to also thank Colonel Mary Lo Mayhew and congratulate her on year number 7 in the Heroes Symposium, the Heroes Journey Symposium. Let's begin today's conversation with talking a little bit about what our experts here have to contribute to today's conversation. And Mr. Andrews, I'm going to start with you. I'd like for you to talk a little bit about your organization. We know that you are the executive director of the American Psychiatric Association Foundation. And I'd like for you to share with our viewers and our audience some things that you are doing there as it relates to connecting communities to resources.
Well, thank you, Deborah, and thank all of the Mayhew Foundation, particularly Colonel Lo Mayhew, for the very generous and kind invitation, as well as the indulgence to allow me to get over to the White House before I came here with you. They appreciate it too, I'm sure. The APA Foundation is the charitable education and philanthropic arm of the American Psychiatric Association. For those of you who don't know the APA, most of you have heard of the DSM. Mm-hmm. So APA is who brought us the DSM. We're now on the DSM-5 TR. And so what the APA Foundation really does is connect science, policy, and community. Mm-hmm. And the way we do that is we try to advance the mental health and well-being of individuals and communities where we live, learn, work, worship, and play. And that rectangle of 5 pillars sits on a 3-legged stool, Deborah, So live, learn, work, worship, and play on a three-legged stool of APA Foundation as a convener. And so when we invite people into conversations about how to help, whether it's scope of practice, whether it's access to care, whether it's pay limitations because we don't prioritize mental health and physical health the same, almost everybody accepts our invitations. And that's not just because we have good food. So APA Foundation as a convener. The second pillar really is around thought leadership. There are 39,000 members of the APA. They are in all 50 states and territories of the United States and 100 countries around the world. There is no subspecialty of psychiatry or substance use that our members don't have specialization in. And we have, through the foundation, access to all 39,000. So if we call them, they're coming. And then the last piece is really micro-philanthropy. And so we will spend on an annual basis anywhere between $2.5 and $3 million a year on scholarships, awards, and grants. And I was just last week with an organization associated with Mass General Hospital and the Red Sox Foundation, Home Base. And Home Base is very tied to Special Forces. And so we were with operators and those who oversee operations in some of our hardest places, doing some of our hardest work, but having some of the hardest impacts. And so a lot of what we talked about was dealing not only with the invisible wounds of war for those operators, but the impact on families.
Sure.
Who have to soldier on as well. So those are some of the things that the foundation does. I'll say more as we get through, but where we live, learn, work, worship, play, and that thought leader, convener, micro-philanthropy is really how we do it, because a lot of times when we give grants, they're quasi-restricted. And so we're able to better connect to communities of care because we're giving you money, but if you're in San Antonio, we need you to benchmark and share with somebody in Ohio.
Well, that's not uncommon, and I appreciate you sharing with our audience about those 5 pillars. And we'd like to take a moment to learn a little bit more about the APA Foundation. I'm going to ask our viewers to watch as we learn a little bit more about your organization.
As our nation's mental health crisis continues, the need for mental health care and substance use treatment remains more urgent than ever. Thanks to the American Psychiatric Association Foundation and the amazing work of psychiatrists and other mental health care professionals, people are finally understanding the power of mental health care. But our work is far from over. Last year, we launched a powerful campaign laying the groundwork that mental health care works. Now, we're building on that momentum and amplifying our outreach to drive action across the nation. We're featuring even more personal storytelling so that more people than ever can see themselves and understand their mental health care options. Most importantly, we're empowering people to ask for help and take an active role in their care through a clear, accessible call to action. The American Psychiatric Association Foundation and its supporters will ensure that more people than ever are equipped to make the call and begin their treatment journey. Because when they take that all-important first step and reach out for help, we are there to help answer the call.
Well, Mr. Andrews, thank you so much for that introduction, teaching us more about those 5 pillars and sharing a little bit more with us about the foundation. So, Mr. Armstrong, welcome again.
Thank you.
And I have the same question for you as we get started. You and I had a conversation to talk a little bit about the amazing work that you are doing at Cabana. And I'd like for you to share with our audience. And the one thing that I thought was really striking was how your organization selected the name Cabana.
Yeah.
So please share with our viewers.
Absolutely, thank you. And let me echo thanks to Mary Lowe for my first symposium. So great to be here. So I lead the public sector team at Cabana, Army veteran. I'm sure we'll get into some of the other background related to community work, but I joined the team 2 summers ago. A little bit about our organization. So we were actually founded in the early days of the pandemic. Our founding team was already working on virtual spaces virtual counseling spaces, and the Air Force Chaplain Corps had put out a call for a requirement to help them engage airmen during the pandemic with enhanced privacy and confidentiality. And so we'd worked on two different, both a virtual platform and a physical space where airmen can join almost like a virtual confessional booth. But as many of you all know, chaplains play an outsized role in units for not just the spiritual, but also the non-spiritual support with that confidentiality. And so very quickly started working with frontline healthcare professionals and supporting health systems. We developed a support model where we're running professionally moderated live groups where individuals have the full veil of privacy. They're not only camera off, but they have added features around being able to mask their voice, use an alias, to really overcome some of the early help-seeking stigmas around getting help. And these are non-clinical groups, addressing challenges every day, from things that you're dealing with in the workplace to challenges at home, particularly in the healthcare industry at that point in time. Certainly high stress, grief, loss, challenging, tough workplace conditions, and burnout. Fast forward to last summer, the team had won third place in VA's Mission Daybreak Suicide Prevention Grand Challenge, and came over to the team to help start piloting our work with VA and other military units, and bringing other evidence-based interventions, so group support models for veterans who've survived suicide attempts, certainly a highly stigmatized subgroup, and thinking of like how can we take the platform and taking in-person models and delivering them in a virtual space with that added privacy. And so we could talk a little bit more about that work. But Cabana, we had originally built these platforms. It was Third Room for the Air Force Chaplain Corps was the original name of that. But as we started working with healthcare, Cabana seemed to be like the nice umbrella term that folks tended to really gravitate toward, where it felt inclusive and safe, and that's where we've gone with the naming, at least. So.
I thought it was very interesting that your team decided to use the term Cabana, and building on a virtual platform and that personal confessional environment. And how has that personal confessional environment been working in your organization?
To date, we've led over 3,500 professionally led peer support groups, and we're seeing high rates of engagement. So we support on the employer side just that ability to be able to drop in for group support and not having to wait, or having something in between, actually getting referred to therapy has been incredible success for us, and excited about being able to adapt the platform for different communities, offering different types of groups. Certainly there's a lot of unique challenges to the military experience, both for not just members, but family members, children, as we talked about all day. So we're excited about continuing to adapt that and taking a community approach to that, and also tapping into peers, professional peers, persons with lived experience, not just from a professional background, but also from common challenges that folks are facing. Tapping into that is then a means to scale that access. We talked earlier about the challenge of having enough providers for the one-to-one support, and leaning into groups as a way of scaling access.
And when we look at ways in which we try to connect families and communities and caregivers to resources right in their community-based environment, I was just speaking to one of our colleagues here that I've been hearing this term that small is the new big. And that's because you find many organizations, many practitioners, many professionals working in an environment where they can connect with people right within their own respective communities. So thank you for that. I'm interested in finding more about the strategies that your organizations employ to be able to connect people to the right resources at the right time. It would be great, Mr. Andrews, if you could talk a bit about maybe the top 3 strategies that your organization employs to be able to serve, support, or close gaps in services. And can you share with us perhaps three of the top strategies.
So one of the strategies, Deborah, is you saw our campaign video. We call that our Anthem 2 video. That is the first anti-stigma video that we're aware of in the United States where you never heard the word stigma, but you saw it. You never heard the term DEI, but you saw it. So there's a way to reach underrepresented or hard to reach. There's a way to communicate, and so we believe that our Mental Health Care Works campaign, that in the first 100 days had 32 million impressions. When we celebrated a year anniversary last year, we were over 350 million paid, earned, social, and owned media channels. All right, and so then, now that we're a little easier to find, like Colonel Mayhew wasn't calling me last year, didn't have a campaign. She found me because we have a Where We Play pillar. And one of the things we do in our Where We Play pillar is we have a 5K race. And we know Colonel Mayhew is an avid runner. We just happened to be doing a race in her neighborhood. That's how we happened upon her. So it wasn't by design, other than divine forces, that we had her in our race, and she did exceedingly well, but that comes as no surprise to anybody who knows her. So we try to meet people in community where they are, and then help them make the connections for us. The other strategy outside our campaign apparatus is because we're integrated with the APA. The reason we were on at the White House today is because our public policy team had a lead and they sent us there. And a lot of times what they're looking for us to do, Deborah, is we need a living experience. Who do you guys work with? Who do you know that can be the best representatives? So today they were looking for youth representatives or families and youth. And so we were able to help facilitate some youth coming up from Florida to be at the White House, briefing on well-being. So that's another tactic where we bring in community to policy, as well as to the imprimatur of our pillars. The last piece, though, is we don't make policy. We amplify it or we elevate it, and so we work hand in glove with our communications team. So, for example, we published this week the second edition of our health guide for faith leaders. Because what we have found in working in community across denominations, more people go to a faith leader for help around mental health and substance use before they ever get to a doctor. But the faith leaders have told us they're not equipped. So where are the people going? We're kind of like Gretzky, right? We're going to go where the puck goes. We're not going to go where the puck is. And so a lot of times, these are coaches. The other thing we were able to do, and this is the last one I'll tell you, because everybody needs to be aware of this if you know any children K-12. So we have a federal grant. We're now in year 3, effective October 1, of a federal grant to bring mental health resources to all school staff. Our program is called Notice, Talk, Act at School. Notice, Talk, Act at School is available to all school staff so that we better help them, Nick, to notice when a student is exhibiting stressors. We may not know what the stressors are, and it's not just the teacher. It's the bus drivers, the school resource officers, the cafeteria worker, the custodian. I notice some stress. Then how do we become, in the talk, a better active listener? And so we give them some tools to become better active listeners. So we move, Deborah, from a difficult conversation to a courageous or comfortable conversation. And then the act is, once you get people in that conversation, they're fully engaged, you got to have at least 1 or 2 ready tools, tips, and resources so that, 988 is a good start, but it can't be the only start because they may not be ready to think they need help. So, Notice, Talk, Act is available free of charge to the school, any school in the United States and territories, free of charge to the faculty and staff, free of charge to the parents and guardians. All you have to do is go to apaf.org/schools. And so those children of the fallen could be getting some help right now. You just have to tell your school administrators, your principals, whoever, how is it my tax-paying dollars are paying for this and we won't bring this resource to our community, right? So those are some of the tactics and strategies that we employ. The only time we get it wrong is if we don't do something live, learn, work, worship, play. If we try to color outside those lines, I
Those
can't
5
guarantee
pillars.
the result. I can't guarantee the result.
Yeah, yeah. You mentioned Mental Cares Campaign, and I am wondering if many of the things that you described in terms of the initiatives that the foundation is engaged in, do they come under the umbrella of Mental Cares Campaign, or is that something separate?
So the Mental Health Care Works campaign, again,
Mental Health Works.
mentalhealthcareworks.org, is really an awareness, literacy, and action campaign around mental health. Because one of the things we have found is that we host the largest pipeline program for psych residents and med students in the world. So when you talk about
impressive.
tactics, we're building the future of mental health because we're working with psychiatry residents in 41 states and 19 countries around the world. And so they get mentorship, they get book scholarships, they get additional opportunities to serve on our councils and committees, not just across the foundation, but across APA. So they're touching generational peers who are already stars. So what the campaign does is, again, it opens the door that there is no health without mental health. And that in this community in particular, there are polarities. So one of the things that we see, is in the military and veterans community, is mental health a weakness or is mental health an illness, right? Everybody knows everything costs, because a lot of times when you try to provide resources, it costs too much, or how much is it going to cost me? The question isn't, Nick, how much it costs? The question is, what is the value of the service or the support that could be provided, right? Let's come with a value-based proposition. Not everything costs, right? And then the last piece really is, particularly again, in the hard to reach, hard people doing hard things in hard places, Deborah, access as contradistinction from misinformation and disinformation. And a lot of times what we hear service members say is that if I tell somebody I got a headache, are they going to tell me that I can't train? If I don't get enough hours of training, then I can't be deployed. And if I can't get deployed enough, then I'm not going to get promoted, and somebody may be telling me it's time to go do something else with your life, and I don't want to do anything else. This is my life, right? But we have to humanize our heroes. And that's the most important thing when we talk about uniformed services and veterans. We don't see them as human beings, they're superhuman. And it's only when they come home trying to rotate back that we can see that there might be something wrong, or they're telling us there's something wrong in some cases, and we just don't hear them. We don't see them because nothing could be wrong with you. You're superhuman.
Yeah, yeah. Well, thank you for that overview, because it gives us a very in-depth look at how you are integrating the kinds of support services that are being made, so that we can look at long-term strategies. Mr. Armstrong, I have the same question for you. Finding out more about the 3 strategies that Cabana engages in an effort to improve mental health care for better and long-term success. Talk to us about some of maybe your top 3 strategies at Cabana.
Sure. The biggest one, very similar to how Raul described, is through partnership. I like to think of us as not just a provider with a solution, but a provider enabler. And one of the ways we're doing that is, tapping into partners, particularly in communities who are already doing this work very well, particularly peer support. For example, we just launched a pilot with the Virginia Department of Veterans Services that has a peer support program where we've trained their peer support specialists in our platform to then run support groups virtually to augment the direct face-to-face and community-based work that they're already doing. And so we love to tap into more of that, where we're partnering with organizations that already have that trust. Other community-based organizations, like hub organizations that have grants from the VA, the Staff Sergeant Fox Suicide Prevention grants, to start to coordinate referrals and services between organizations for veterans with multiple needs. We know we want to get them into VA care because the health outcomes are better, but at the same time we know that there's a gap of veterans who may not have that trust. And so how are we supporting and coming in alongside those organizations of creating another capability for those organizations to reach and serve those veterans that may not be ready for direct services. Within the platform also, a lot of this was talked about earlier in terms of the types of groups, the types of content that is in the platform that we're providing access to. Certainly we talked a lot about sleep and physical activity and exercise, just the basics of like the connection of physical health to mental health, but also building skills. We've got a lot of psychoeducational content in there. We like to think of your favorite comedian or Will Ferrell and a therapist create a TikTok account, creating content that is easily consumable to users who may not have an hour to drop into a support group, but may have 2 minutes to just learn about something. And if we know through evidence that if folks learn about a particular topic, they may be more likely to seek support. And so both the strategies in terms of how we're partnering in communities with trusted and trusted agents, and then providing content that is easy to consume.
So I hear you talk about peer support, partnerships, and providing content. There's been a lot of studies that lend itself to the affirmation about the value of peer support. So I'd like to peel back the layers just a bit and have you talk to us a little bit more about the effectiveness of your peer support program and how does it run?
Yes, so the peers on our platform, this is actually new for us, but all of our groups are led by professionals, so LCSWs, LPCs, but the groups themselves are professionally led. They're the only ones who are on camera. The rest of the individuals have all these other privacy controls. And so we have licensed professionals leading the groups, but with lived experience. That's very key, particularly if we're running cohorts or smaller groups for specific populations. Particularly for the VA pilot, where we're looking to support veterans who survived suicide attempts. That's a very high acute group. So we have different types of moderators or peers or professionals with a combination of lived experience and training credentials.
Well, I'm hearing that there's a lot of similarities, obviously a lot of distinctions in what your organizations contribute to the communities at large, but there's a lot of similarities. I'd like to find out a bit about some of the challenges that you either experience or see that's going on in this particular space. So what are some of the challenges that you guys are facing at the APA Foundation?
So the first challenge continues to be that while in the history of humankind, mental health awareness is higher than it's ever been, access to care continues to lag significantly. So part of that is because we have not adopted a cultural value set that tells us whole health equals physical health and mental health. The very term primary care, the fact that we've allowed that term to exist and primary care doesn't have mental health in it. Anybody who knows anything about the human body will tell you that when you stub your toe, how do you know it hurts? Because your mind is telling your body that you stub your toe and it's supposed to hurt, right? So if your mind is telling you what to feel, how have we disconnected it, right? It's almost like when Milton Bradley created that game, Operation. Mental health lost it forever because we're not focused on the brain and the mind, we focused on the limbs. So access to care continues to be a problem. There is a pay lag. The reality of it is that in many instances, our carriers don't reimburse for mental health the same way they reimburse for physical health. And so a lot of times our clinicians, our physicians, psychiatrists, don't go into healthcare plans. Most people can't afford to pay $400 an hour to get medical. They need some insurance.
That's true.
So that's another barrier. And I think the last one, again, really continues to be the disinformation and misinformation campaigns that are out there that somehow are boogeymen. You know, our villains on all of the movies we love are psychotic geniuses, right? Like, I mean, they just, you know, they haven't figured out, but they're villainous. And so we're afraid of the unknown. What's it behind that Arkham Institute, you know, and all these kind of things. So, and the reality of it is, for every mental health care works campaign ad and the good we could do for 5 minutes, in 5 seconds it could be snuffed out because somebody says something that's incorrect or knowingly false about mental health care or substance use. So those are the things that we really struggle with because we just don't have enough people to do it. So one of the message I do want to leave with our care team, one of the things we've asked the whole House of Medicine to do as a part of Mental Health Care Works is be more receptive to treating the whole patient. So if you're going to see a gynecologist and that person asks you how you doing, don't just say fine and let's get over with. You're going to get a pediatric physical for a young child, you know, let's make sure we're asking all of the right questions. You know, if you got heart issues, you know, I was with a cardiologist last week, Deborah, he told me, like, hey, you know, here's the emotional or psychological component to heart health. You find out you got heart disease, we got to open you up. I tell you that on Wednesday. I'm cutting you open next Wednesday. I'm not doing anything for a week. So get ready. You got to sit 7 days thinking about, I'm never going to be able to be the same. I'm never going to be able to eat the same. You know, all these other things that have to change in my life in order to live if I survive the surgery. That's all psychological. That's all emotional. So the reality of it is we cannot have whole health if we don't focus on our mental health. And I know it's hard, but we have to do it.
I am very pleased to hear you obviously not only talk about access to care, because that's something that's universal in many of our organizations, and that's just a challenge. And that challenge is perpetuated by the lack of talent, the lack of resources in many different spaces. But to hear you focus in on this whole health and the whole health approach, being holistic, is really what we want our viewers and our participants to be able to focus on, because that's the goal. How do we get to a national framework, a national blueprint on holistic health? And so, and giving us some feedback on your thoughts about some of the big challenges, and it's not just challenges that you may experience in your organization, but what are the challenges that you observe in the industry at large as well?
Sure. Even tapping back into my prior work before joining Cabana at Syracuse University, we were involved in helping to support communities build integrated referral networks, you know, really addressing social determinants and access. And a lot of different models have popped up through the last 10, 15 years. And a lot of talk in the early years around, like, what's the blueprint? Like, how do we, you know, how do we pull organizations together to improve this navigation challenge that military communities are facing, particularly for those who are in transition, and being able to serve better those that often don't just have one need. When they have one need, it's rarely they walk into a social services organization, I need a job. It's usually a job and 2 or 3 other needs, and how do we think about the user and their needs and then create that, that network. But I would say at this point that I don't think blueprint is necessarily like the best way of thinking about it. At least for me, my personal opinion is more a set of maybe guiding principles in terms of how communities can work. And I think, again, you know, first understanding the needs and resources. I think Shelley talked about that. She's involved in a lot of her work in Indiana, but understanding, like, what's the capacity of a community and what are the needs in the community first, and just taking stock of what is there, and then leaning into local champions, whether it's it could be a faith-based organization, it could be a mental health system, or something in between. But who are the actors that carry the trust and the capacity then to be able to pull others in under the tent, and then other local champions with resources. It could be foundations, it could be government, combination thereof. But there's no one necessarily right recipe, but maybe sort of some lessons learned over how these communities have been built and developed and sustained over the last decade.
I like how you soften that approach of a blueprint moving to a space of guiding principles, and it gives us permission not to have such rigid edges around how do we create something that can have impact and have some efficacy on a national level. And if we look at guiding principles, it gives us a lot of dexterity to be able to move in and out of it. So I like how you soften the edges in talking about a blueprint and moving into guiding principles. I'd like to shift gears ever so slightly and talk about technology. And I know that you're working in a virtual environment and working on that sort of platform. But I'd like for you both, and I'm going to ask you, Mr. Andrews, about technology. What is the impact, or how is it enhancing mental health and wellness, not only in your organization, but in the communities? I say with an S because we said small is the new big, in the communities at large. How is technology affecting our ability to come up with this holistic approach?
So there is no question that telehealth, telepsychiatry has increased access to care because you've not only removed a travel burden, which could be mobility or social determinant, right, Nick?
Yep.
But the reality of it is some of that shame, because now somebody doesn't have to see me going in or out of the office to see a therapist, a psychiatrist, a psychologist, because I'm online. Even though that we know there's still a digital divide. 85% of all psychiatrists in the United States are now doing all or partial telepsychiatry. And we have some physicians who don't even see in person anymore, and have been allowed to do so since the pandemic. The other thing we've seen, technology, it has moved the dial in the prescription drug space because they've been able to come up with new medications as well as new modalities of regimen for treatment that we could not have done without the advent of technology. On the downside, though, I will quickly say that we are struggling with how to incorporate artificial intelligence into clinical practice, because the reality of it is, for every hour of patient care, there are at least 2.5 hours of healthcare records. For every hour of patient
I was
care,
going to say that again.
for every hour of patient care, I got 2.5 hours of paperwork. And
Wow.
that is now more often than not electronic health records. So the challenge becomes, how do we make sure that AI is not documenting all of our records and without the appropriate human oversight? And we're not thinking we have a problem with it, but I think that's one of the reasons why we've gone slow to full-scale incorporation of AI, because we're not just trying to make donuts, right? These are human beings.
Sure.
And if you, I saw a gazillion patients today. And I got to do the paperwork that goes with a gazillion patients. And then the last piece, from the burnout well-being of clinicians, I think one of the things we've heard, which is kind of a downside, people don't miss appointments as much anymore when it's online. So what used to happen is the irritation and the little nasty gram that we all are familiar with. You missed your appointment,
Yeah,
and we're
yeah,
disappointed.
yeah.
Let us know if you want to reschedule. Zoom to Zoom to Zoom, Teams to Teams to Teams. Nobody really is missing appointments. So now I don't even get that hour or even that 15 minutes of a break, because that patient's waiting in the waiting room when I pop them up. So those are just some of the ups and downs of technology in terms of innovative treatment plans, access, but on the downside, overload, because we can now have our clinicians see more patients.
As you started to respond to that, I started thinking that there's two sides to this coin called technology. But by the time you finish that explanation, I'm thinking it's not two sides to this coin. There are multi-facets to this. And when you talk about the struggles with AI, one of the things that popped into my head, and you all may be able to empathize with this, is when we started using our smartphones with that autocorrect. And with autocorrect, your message could say almost anything at the end of the day.
Yep.
And so when we're looking at the support that you get from AI in terms of completing records, it could very well be missing that human element of how is autocorrect, in this case, artificial intelligence, correcting or completing that work in terms of documenting files and records. So I'm seeing that there's multifacets to this. In addition to that, you both made mention, you said that technology is having a positive impact on reducing some of the shame. And that takes me back to what you were saying earlier about those personal confessionals. And so with the personal confessionals, and I still love this name, Cabana, that participants have. So talk to us a little bit about, again, technology and how that's working for you.
Sure.
And maybe having some cautions with that.
Sure. Yeah, and I'll start just as an echo around the challenges. You know, like we live in an Amazon society.
Yep.
Like now
right.
expectations are I can have anything at my fingertips. So then how are we leveraging technology to deliver services and support like on almost instantaneously? And so, you know, our platform was built with environmental psychologists. So we initially, you know, partnered with some folks at UVA to imagine what would a space look like that offers psychological safety, where you feel safe. And we initially built the counseling platform in VR, an immersive VR setting. So you think, you know, wood tones and nature, surrounded by nature. You know, also thinking of the ability to sort of look away from who you're engaging with. But we're not a VR company. We're always thinking about like how are we meeting users where they're actually going to use the technology and making changes and adaptations as we need to. You know, you mentioned the controls over privacy. That's still huge. And so, how are we continuing to innovate on that as a way for folks to feel like they have full control over the privacy, and you know, other elements of the technology, just being able to adapt that as we evolve.
So it's interesting that you talk about having control over our privacy. So when you talk about psychological safety, that would be the one thing I think that some people may find that troubling. So is that a benefit, or is that something that may cause some levels of anxiety?
The technology? I'm sorry. Well, I think we're really trying to position the experience to accelerate support to the human connection. So if this becomes one other access point where you're really reaching those who may not be ready for a one-to-one interaction, and that's where we're seeing the fit for this type of support.
So I appreciate the similarities that we're hearing in the important work that you both are doing in your respective organizations, in your respective communities on a micro as well as a macro level. I'd like for us to begin to pull this conversation together and have you both talk a bit as visionaries. And as visionaries, we already talked about, we softened the edges around a blueprint. But my question was going to be, what does a blueprint for holistic health look like? How does that manifest itself? And so whether we're talking about a blueprint with the softer edge that I love, which is guiding principles, how does that manifest itself so that we can arm, prepare, and educate our colleagues in this space? A blueprint for holistic health. What do you see as a visionary of what may come over the horizon? Mr. Andrews?
Every time we hear, see, or tell a story about the human condition, in or out of uniform, that's a mental health story. We just have to know that. So I think as we look to the future, you know, it has often been said that the best way to predict the future is to create it. That is one of the reasons why we invest nearly $2 million every year in a pipeline program that goes upstream to reach medical students. And in 2025, we'll be reaching college students because the original STEM was medicine, not coding. So we need to get people, don't have to be a doctor, but you could be a health professional of some kind, because in order to get whole and well, Deborah, the whole healthcare team has to be involved. We know we spend more time with nurses than we do with the doctors. So there could be some nurses. We know pharmacists are doing things with injections nobody ever knew pharmacists could do. People could be pharmacists, be a part of the whole health team. Then I think the second thing we got to do is level set our expectations around mental health. So if I were to break my arm, heaven forbid, it could be reset, they could do something, and in 6 to 8 weeks it would be better. Now I know it's not 100% of what it really was before I broke it, but it works. When it comes to mind health, we want to be happy. And the reason why I didn't come to you in the first place as a clinician, and the reason why I don't want to come back and I don't want to be on medication, is because whatever you're talking to me or whatever you're telling me to do, it's not making me happy. We're talking about being whole and well. We might be on a journey to happiness, but whole and well has to be the goal. So if we level set our expectations, then I don't think we're disappointed that I keep going to see this person or I keep going online to see this person and I want them to make me happy. And talking to therapists is not making me happy. That's not the goal. It's to make you whole and well. And if you're well, then we can look at some of these lifestyle resources that Nick correctly observed, because if I'm on a wellness journey, I'm sleeping a little better. I'm eating a little better. I'm exercising or moving around a little bit more. My social circle is healthier. You know, a lot of times we don't cut out some of the people that are making us unhappy or stressing us out. And when we can cut them out, we got to cut them out. And sometimes those are people, and sometimes those are devices. So, you know, even in my own journey, you know, I have been coached that, you know, for the first 30 minutes of every day and the last 30 minutes of every night, I need to power down or put my device outside of arm's reach. I'm up to 20 minutes in the morning. Up to 20. I ain't gonna talk about night, but I'm a night owl. But I'm up to 20 minutes in the morning where for the first 20 minutes, try it for 5 for the rest of this week. Just try to get up for 5 minutes and don't flip that device over. There was a time, and I know I was late here and I'm glad you indulged me, but there was a time where if I left my belt at home, I would have said, tell Colonel Mayhew I might not make it because I got to go all the way back to Maryland, get my belt and come back. Now, I probably would have been grabbing my pants by the side. But if I leave my device behind, I can't even function.
Right.
And in 2006, I didn't even have one. But now all of a sudden they're telling me I have to have an iPhone. Do I? So just try it for 5 minutes up. Maybe try it for 5 minutes tonight. 5 minutes, that's all, just 5 minutes. And let's see what happens.
So the question is, do you have to have your iPhone? You've gone through this 20-minute experience. Do you have to have your iPhone?
I still believe that no matter what I said, whether you agreed or disagreed, raw and real is better than raw AI. I still think I'm better than raw AI because raw AI would not have done all of the stuff I did today, including make a commitment to be here and still come. Raw AI would say, if I go through the analytics, you know, if I just send an email and stuff, I mean, they got enough professionals in that room. Everybody in here could have taken my spot. I'm sorry, Colonel Mayhew, but you know, we're gonna sponsor your thing again for the 8th year, so just forgive me and I'll see you at the race, you know. But real raw says,
He'll see you at the race.
real raw says, you said you were going over there, be polite as you exit your way out of here, but you have to go over there. And we'll deal with tonight with my last 5 minutes. I got one more thing to do when I leave here. I tell you, raw AI wouldn't be doing one more thing when I leave here.
So I am wondering, we look at blueprint versus guiding principles from a visionary perspective. What are some of the things that you may envision or would like to see on the horizon in terms of coming up with guiding principles, in terms of holistic health, for us being able to provide services that give people the right treatment or the right support at the right time?
Yeah, I mean, it comes down to our vision is to make getting access to mental health support impossible. And that's through a combination of clinical and non-clinical support in our view. You know, I often see some similarities, almost the mental health technology space is a microcosm where the veterans social services space has been over the last 10 years, where you've got silos of excellence and a lot of great organizations doing great things, but it creates challenges for the user. So how can we not just be another point solution, but integrated in being able to provide things that we do well, across the continuum of behavioral health support, particularly upstream and downstream, but also being able to integrate back into providers so folks can navigate to the services they need more quickly than how they're getting supported today.
So I ask you both, is it a Pollyanna sort of a perspective in thinking that we can come up with something that is going to be able to be a blueprint or a guiding principle on a national level? Because there's so many nuances to being able to provide the kind of effective support and services. So is that a Pollyanna perspective that we look at trying to come up with something national?
I hope it's not Pollyanna. I think, part of it comes down to some of these innovations too, don't map to traditional payer models. So how do we think about working with organizations, interventions, and partnerships with research and academia to test and build evidence? We talked about that earlier today. But how are we thinking about resourcing needs to bring other ways of supporting outside of the clinical to bear?
If we can get out of Nick's silos of excellence, so what if it is? We have to do hard things. And we're not here to play, we're not here to dream, we're not here to drift. So let's do the hard thing because we choose to go to the moon. Not because it's easy, but because it's hard. So even if it is Pollyannish, that has to be the North Star. And we have to keep fighting for it, even if we have to do it neighborhood by neighborhood, even if we have to do it city or county or town by town, if we have to do it state by state, because the reality of it is that's what we deserve. And if we deserve that, we need to be working to get it. And if they give it to us, we got to fight to keep it. And if anybody can figure out how to do that, it's the armed services and veterans community. And we're ready to stand behind them and support them as they lead the way to get us to a better state.
Well, it has been quite enjoyable and informative listening to what each of you do and your organizations do in your respective space. And before we thank you and bid you good afternoon, I'd like to find out, is there any one thing that we didn't cover that you'd like to share with our viewers before we close out this panel discussion?
Sure, I'll start. We actually launched a new social impact initiative last month, leading into Suicide Prevention Month, called Cabana for Good. So we're partnering with nonprofit organizations. Any nonprofit organization in good standing can get up to 10 employees covered on Cabana at no cost. And that's right on our website, and we're excited for that. We've already got a dozen or so nonprofit partners that have joined us, and would love to get that word out.
Can you give us that website again?
Sure, it's cabanaforgood.com.
Cabanaforgood.com. Thank you so much. Final words?
So we talked a little bit today about Whole and Well, and we did launch in July a lifestyle psychiatry prevention and wellness campaign, which is underneath our Mental Health Care Works campaign. And so we are going to be talking about the 6 pillars of lifestyle medicine.
Good.
And we are the last house, psychiatry, in the House of Medicine to talk about lifestyle. And so now we have persuaded our docs that if we don't bring restorative sleep and diet and other exercise, so we look forward to sharing more. But the one announcement I do want to make here is that we want to be the first partner to pledge our support for the 8th annual Mayhew Foundation Convention this time next year.
It's nothing like being first, right? Nothing like it. Well, gentlemen, thank you so much for joining us here at the 2024 Heroes Journey Symposium. Thank you for kicking the ball off for 2025. We're going to look forward to that. And we're also going to look forward to your continued contributions in this space as we all work collectively connecting people to the right care at the right time. Thank you, gentlemen.
Thank you.
Sir, the military is made up of a lot of young folks, and a lot of young folks, men and women, suffer from post-traumatic stress. Yet the APA continues to call it post-traumatic stress disorder. Now, young folks don't like to have disorders, and they don't like that put on their records, and they don't like to be told they have a disorder. I consider it a barrier to care. Why do you insist on calling it a disorder?
So I will let the scientific program committee speak for that, but what I will tell you is it is an illness, and we want it to be treated as a medical illness, and it is not. It can be mitigated, but in many instances it won't be cured. And so because of the stressors that cause it, that is the label. But if you would be, I'll share my information with you, and I will not be unhappy to share your feedback, because I know we're working on DSM-6. And I can't guarantee you it'll be changed, but if we don't get inputs from the outside, there's no chance it'll be changed. But I appreciate the feedback.
Tried to get it changed to DSM-5, but it didn't work.
Yeah, but that ship has sailed. So I think we got to focus on 6 now.
Okay.
That really is an excellent question, and I think that when we look at going to the next cycle, we live and work in this dynamic sort of environment with lives changing, circumstances and resources changing, and I encourage you to continue to bring up that question, and thank you so much for taking it back, because the truth is that there were things that were identified in a certain way years ago that we don't recognize them that way now. So thank you, that was an excellent question.